Hemodialysis. In general, peritoneal dialysis doesn't work or is contraindicated per the provider. Then the first thing we really need to do is make sure our client has access, vascular access. And sometimes this is done emergently in ICU if our patient's critical. Remember we talked about the critical times? What would those be?
Hyperkalemia.
Good. Hyperkalemia if it's really high, right? Or hypervolemia. Too much volume, right? So we have to do it emergently. We need a quick access. Very often they'll put a temporary access in, a Quinton catheter, or a tunneled catheter. So, and they'll usually do those in ICU. They can do them at the bedside, or they can do them in sometimes interventional radiology, sometimes OR, depending. Okay, and we're going to talk about the access sites. But in general, we talked about hemodialysis. Hemodialysis is an artificial membrane. So this is an artificial, like cartridges. They look like little tubes, okay? They're made from cellulose-based synthetic material. And then this is used as a semi-permeable membrane. So now we're not going to use a part of our body. We're using something man-made, right? So it's a bit different. And this comes into contact with the patient's blood. The gradient is created by increasing the blood compartment or by decreasing the pressure in the dialysate compartment. An extracellular fluid moves into the dialysate because of the pressure gradient. The excess fluid is removed by creating a pressure differential between the blood and the dialysate solution, causing removal of the waste. Bless you. So to do hemodialysis, we require a vascular access using a large vessel required for rapid blood flow. So these exchanges are done by rapid blood flow. So we have to use an artery and a vein to do this. And we're going to talk about the different types of accesses that we need this requirement, that meet this requirement. Like I said, we can use a temporary access. And they're double lumen for blood removal and return. And sometimes they're cuffed. Those are long-term catheters. Okay? So different types of temporary catheters are called the Quinton catheter. Have any of you guys heard of Quinton catheters? Those are the most common ones. There's also Kendall, Hickman, which are tunneled. These catheters are not to be touched. You guys okay? Passing things back? Okay. All right. They're not to be touched for meds. So we don't use them as nurses on the units, right? They're not to be used for lab draws. And only the dialysis nurse cares for them. Right? Only the dialysis nurse will care for these catheters. Why do you think that is? Because we put large amounts of heparin in them. The dialysis nurses use large amounts of heparin in them. And if we came along and flushed them, what would we do? We would lose all that heparin. Yeah, and that catheter could clot off if we did. So we don't touch them. The only thing we could do with these catheters is change the outer dressing and monitor the site, your insertion site, for signs of infection, and change the dressing if it becomes loose or soiled. But other than that, we don't touch them. The long-term catheters are cuffed. Okay, those are cuffed catheters. Here's just a picture for you. Next, we're going to discuss the grafts. So the different types of access are arteriovenous fistulas, AVFs, or arteriovenous grafts, AVGs, they call them. And then, of course, we talked about the temporary catheters. So we talk about the fistulas. A subcutaneous arterial venous fistula is created in the forearm with anastomosis. That means kind of like tying together. Have you guys heard of the word anastomosis? Okay. So it means like tying together an artery and a vein. Usually they use the cephalic or the basilic vein. The fistula allows for blood to flow through the vein. Now the vein becomes arterialized, which increases in size and thickness. So this kind of allows rapid blood flow. It's like they get tougher over time. So as the fistula matures, it becomes more easier to venipuncture them. It's like they get tougher and they can sustain more venipunctures. Sometimes it takes weeks for them to mature or months. Depends on the surgeon. They will vary with this, but it can take months before they'll use it, because it takes time for it to mature. About 4 to 6 weeks. Your graft, your AV graft, is made of synthetic material. Okay, and it takes about 2 to 4 weeks to heal. Okay, and this is again a bridge between our arterial and venous system. But what's the difference with the graft? What do you think could happen with a graft being synthetic? Right, yeah, it can get infected, and also what? Things can stick to it, right? And it form clots, okay? So they're more prone to thrombosis. Okay. So how do we know these are working? Anybody know? Anybody check this on a patient before? What do you hear? Good. And what does it sound like? It's almost like have you ever been on a sonogram with a baby and heard the heartbeat? I know that's what it sounds like to me when you hear this swoosh, swoosh, swoosh. Real loud swoosh kind of sound. And what do we feel for? Thrill, right? You feel it too. If you put your hand on it, you'd feel it. Okay? So that's how we know they're working, they're functioning, right? So we should check that how often when we're on duty. Yeah, at least every shift or before we're sending our patient to dialysis would be a good time, right? And what do we not want to do to this arm with a new site? Good. We don't want to have any blood draws, blood pressures, labs, and we want to assess for infection, right? So usually the patients are really well educated with this, but I know where I work we have those like stop tattoos, so we know not the CNAs know not to touch that arm. Some places will put a sign over the head of the bed. It varies facility to facility, but generally you definitely don't want to do anything that can compromise these devices. And the grafts are usually made of Teflon, and they do form a bridge between the arterial and the venous blood supply. And they are surgically anastomosed. And again, they are likely to become more infected and thrombose. If this happens, they have to be removed. Okay, remember these go pretty close to circulation, so when they get infected, it's probably going to be sepsis, right? Because you have rapid circulation, and these just carry right into the bloodstream. So, very dangerous, right? Okay. So we talked about hemodialysis, the dialyzers. We talked about how hemodialysis works, general principles of dialysis. Works with a pressure gradient. The blood enters into the dialyzer, which has the fibers. The dialysate is pumped into the cartridge and bathes the fibers with ultrafiltration, diffusion, osmosis, like we talked about earlier. And this occurs across the fibers of the semipermeable membrane, which is synthetic, and then the blood returns to the patient. I think I have a picture. Here's your picture to show you. So you can see the patient's, I'm sorry, go back. Sure. So large bore needles are inserted into the fistula or the graft to obtain the vascular access. And then one needle kind of pulls the blood from the circulation to the dialysis machine, and the other returns the dialyzed blood to the patient. And I actually have a video, which I'm going to show you after this, on a patient getting dialysis. So they use tubing to attach the needles. Okay. So here's your picture of your patient. And you can see, I mean, this is just symbolized, is that word, symbolized picture of a patient getting dialysis. So you can see it's kind of like a circle. It goes through the filter and then returns to the patient by those needles. And they use a saline solution to return the blood back to the patient through the vascular access. And when they remove the needles, they put very firm pressure on the venipuncture site. Why do you think that is? They are really prone to bleeding, right? Especially that's one of the bleeding places where it happens most oftenly. So they sometimes will even use clamps, I've seen them do, and really strong pressure tape to, once they de-access the needles, to make sure our patients don't lose too much blood. So, here's just a picture of a catheter. Okay, red and blue colors, right? And if you really aren't sure what your method is, whether it's a venous, AV fistula or AV graft, where would you look? Good, in the chart, in the record. You would look in the op note, right? In the operative note, and see what the surgeon put in, if you're not sure. I'm always reading about my patients. When the more you know about your patients, the better you can take care of them. So you know their history, you know what led up to it, and you know what is working for them, or what the plan is from the doctor's perspective. You just need a rapid flow of blood. So that's really the reason. So you can eliminate waste in a timely manner. Does that make sense? That's a good question. Yeah, it's just they need a rapid blood flow. Okay. All right, so we're going to watch when we remove the needles from the venipuncture site. We want to make sure that bleeding stops. So we know our patients are, one of the sites that is high risk for bleeding is when they remove those needles. What do we need to do before we start dialysis? Wait, right? Again, we have to get a wait. Good. Vital signs, usually blood pressure, temperature. We're going to assess for what? What are we assessing our patients for? Heart and lung sounds, right? We want to make sure, sometimes, like I said, you can be really overloaded before dialysis. Think of massive amounts of fluid shifts, right? Pre-dialysis, your patient has all this volume, right? And then once they get back from dialysis, they're dry, right? So you may be overloaded before you go to dialysis, and then when you get back, you're dry. They take off all the fluid, right? And they can take off sometimes 3 to 4 liters, which is a lot of fluid. Sometimes it's 1 to 2, depending on your patient. But they take off a lot of fluid. So before dialysis, typically what would we hold? Blood pressure medications, yeah, because you know they're gonna be low when they get back. So typically we hold our blood pressure medicine before we go. And some medicines are dialyzed out, like antibiotics. So they may give them through the dialysis machine or at the end of the dialysis. They will do that. A lot of times patients will receive blood transfusions during dialysis. So the way the nephrologist determines, yes?
For a scenario like that, would we call the doctor first before holding the blood pressure and getting like an approval, or do you?
No, we just hold it.
Okay.
Yeah, it's okay to do that. Yeah. They know. Typically, the doctor uses the weight before the dialysis treatment to the next one. Once they come back from the first one to the next one, and they compare, and that's how they determine how much fluid to take off. Did you have a question back there? No, or are you stretching? Just doing a stretch? Okay, that's fine. All right. So that's how they know kind of how much fluid to take off. They use those weights. So that's why it's so important to do what with our patients when we weigh them. Make sure it's accurate. Same scale, good. Same scale, same time every day. If we can get a daily weight on them, it's really important to teach our patient too, to make sure that our weights are accurate. I've seen like 20 kilogram differences in our weights in the hospital. And I don't know if they're just not converting pounds to kilograms, what the issue is, but but you see it all the time. So just look at your prior weight. Is it like close to it? Is it not? Then something might be wrong, right? So anyway. Complications of AV fistula. What can happen, not with dialysis, but just with AV fistula or graft, what can happen is called Steele syndrome. Have you all ever heard of Steele syndrome? It's a term used to indicate blood is being stolen away. Okay, so this can occur after surgery, and it happens distal to the fistula site. So the way you would assess for this is your appearance of your extremity, right? If you had a graft on the left arm and you see your hand is pale and cold and painful distal to the fistula and poor cap refill, right? That's another thing you would check is cap refill. Then you know you have no circulation to that hand. So that's something that is a surgical emergency and needs to be corrected, and they can't use that site. Okay, so that can happen. It's called Steele syndrome. I would focus on that. It's in your book. Oh, here's a picture of those cartridges from the dialysis catheters, from the dialysis machine. This is what they look like. They're man-made, like I said, used for dialysis. They come in different sizes. Okay. I'm going to come back to the videos, no worries. Okay. Advantages of hemodialysis. Let's see if okay. And this is in your books too. We can have pretty quick relief of symptoms, right? Like I said, we have massive amounts of fluid shifts, right? From being overloaded and then being dry, right? One time I had a patient who came back from PACU, and I said to the PACU nurse, you know, he's in distress, and he was short of breath, he had JVD, he was having chest pain, his blood pressure was 200 over 105. Yeah, he was in trouble. And then I looked at the bag that the dialysis used, and she used a temporary catheter. There was like 2 drops left in the bag. So a whole liter in the PACU went into this patient. And it was a dialysis patient. And the dialysis had the graft. That was the procedure that had been done, was a graft was put in the left arm on this patient. So I had to call a rapid response team because this nurse gave this patient too much fluid. And I had to, even the rapid couldn't really help me because what I really needed to do was dialyze them. It's not like you can give these people diuretics. You can't. It's not going to help them. You have to call in a stat dialysis team. So I did that. And meanwhile, he went to ICU. and he did live. But you have to be really cautious and on your toes when you're taking care of our dialysis patients. Fluid balance is very important. So, that being said, after they come back from dialysis, what do you think the most common complication is? Hypotension. Yeah, hypotension, unfortunately. And anemia. So why do you think they can get anemic? Right, that, and they can potential for bleeding. They sometimes the blood gets destroyed during the dialysis treatment. So they're generally requiring multiple, bless you, blood transfusions. So because they require multiple blood transfusions, what do you think that leaves them predisposed to? Infection, bloodborne pathogens, right? So such as what? What are the most common ones? Hepatitis. And hepatitis B we have a vaccine for, but C we do not. So very often our dialysis patient is positive for Hep C, and there's 20 different bloodborne pathogens patients can get, even malaria. So they can get so many different things, HIV, all different kinds of complications from. So it's risky getting dialysis. But again, a lot of these patients don't have a lot of options. Fatter they die, right? So we can relieve some immediate symptoms when we give dialysis, but we also get complications. And we can try to prevent complications as much as we can possibly do that. We do rapid fluid removal with hemodialysis. So this patient has to be able to tolerate those rapid shifts in fluid. They have to be pretty strong cardiovascularly, right? Because it's definitely a stress on your heart. All that fluid going off your system and on your system, right? It does remove waste products. Of course, that's the goal of it, right? And it's usually done, it can be done at the bedside over 3 to 4 hours. Often it's done in like an outpatient clinical setting or dialysis center. There's a lot of them out there. And some do it at home, but you can imagine how difficult it would be. So it's not that common to do it at home. And I'm sorry, what? No. Yes, for hemo, it does require a lot of heparin. Otherwise, it can clot up in the machine. So they use a lot of heparin in the machine, to make the blood keep going through. And just the fluid moving will prevent the blood from coagulating, but they do use a lot of heparin during hemo. Good questions. So other complications are muscle cramps. They're not really sure medically why that happens, but it does, and this probably has to do with the massive fluid shifts. Again, we talked about hepatitis. Of course, vascular access problems, infection, and so forth, thrombosis. Just make y'all laugh. Yes, it requires heparin. And you have to have surgery to access your sites, of course. It's a surgical procedure. So is getting your peritoneal catheter too, so. Okay. So again, nursing management, this is obvious. Again, we talked about this. We're going to monitor your weight, your blood pressure, peripheral edema, JVD, eyes and nose. Not everybody is anuric. Some people still produce urine. Of course, our lung and our heart sounds, condition of our skin, our access site, temperature. And we're going to educate our patients and our family about the blood pressure and the fluid shifts and what happens and so forth. Right? Okay. So blood loss can come also from the blood not being completely rinsed from the dialyzer. Sometimes the blood accidentally, the tubing accidentally comes apart with a dialysis nurse. The machine can malfunction, rarely, thankfully. So these nurses really need to know how to troubleshoot the machines. Dialysis membrane rupture can happen, which is kind of scary because then the blood kind of just goes everywhere, right? They can exsanguinate, which is really scary. Again, too much heparin can happen, and they can bleed a lot, like we said. So they do get frequent blood transfusions. But the most common cause of death is what? Mrs. Lewis said this last week. Good. Someone was listening. Very good. You get a candy. I'll give you one later. Cardiovascular disease, right? And infections are the second leading cause of death. Okay? There's also a syndrome called disequilibrium syndrome. This is kind of a nice to know. Urea, sodium, and other solutes are removed more rapidly from the blood than the cerebrospinal fluid. So it causes an osmotic gradient, and it's just kind of causes brain swelling. So we can give them some, we can either slow the rate or stop the dialysis. Sometimes they'll give them a hypertonic solution to shrink the cell size in the brain. But it is a pretty serious complication. You'll notice your patient can vomit, they can become confused, restless, bad headaches, and they can have seizures. Think of cerebral edema, that kind of thing. I think I've seen them give mannitol for it too, but it's just a nice to know, but good to know, right? So they would give a hypertonic solution for that. Okay. So checking our weight, our blood pressure, our labs before. And you'll see your nephrologist will be looking at those closely because that's how he knows what to order during dialysis, he or she. It's usually done 3 to 5 hours, about 3 times a week. Most of my patients are Monday, Wednesday, Friday. Some are Tuesday, Thursday, Saturday. But they'll try to accommodate the patient as best they can. Again, we talked about the process, about priming the machine with saline. We use the heparin to prevent clotting in the machine. The blood is pumped 200 to 500 mLs per minute, so it's super fast. And the dialysate is at 300 to 900 mLs per minute. These are nice to know, as you don't have to commit this to memorization. But we do need to monitor BP every 30 minutes during dialysis. So you'll see your patients that those nurses are taking blood pressures almost every 15 minutes. Some do it every 15 minutes. We're watching for hypovolemia. And do you think these patients should be on telly? Oh yeah, right? Because what can massive fluid shifts cause? Electrolyte imbalances, right? So, plus we're really taking that potassium down pretty quickly, or so there's massive fluid shifts, which can cause huge dysrhythmias. So that's why we're watching telly, right? Telly. Okay, is that too fast, or you guys need me to go back? Yeah? Sorry. So just know the biggest complication, hypovolemia, right? Good. Are we good? You need more time? Yeah? Anybody saying no? Okay. All right, diet. Of course, we have to watch our diet. And there is a comparison sheet in your textbook on page 1082. And test questions love these little boxes, right? So, nutrition-wise, for hemo, we can, for fluids, right? We have urine output plus 600 to 1,000 mLs. For hemodialysis, for peritoneal dialysis, there's no fluid restrictions. I would commit that to memorization. Know it. Protein. Okay, for hemo, we are limited. Peritoneal, it varies, but it's almost the same. Recommendations. Calories fluctuates a little bit, right? But you do need to have calories. Carbs for hemo is unlimited. Unlimited carbs, right? So that's a good thing. Sodium is 2 to 3 grams a day. For hemo, peritoneal is 2 to 4 grams a day. Potassium is restricted for hemodialysis. We'll just know that. 2 to 4 grams a day. For peritoneal, it's not restricted. Okay? Phosphorus, 6 to 1.2 grams a day. It's pretty much the same, but it is restricted. Okay? So you don't want to give them too much. What kind of foods have phosphorus in them? Milk products, right? So we got to kind of be cautious with too much phosphorus, right? And you might want to know what types of foods have a lot of potassium in them, right? For hemodialysis, we got to watch our potassium, right? So we have put them on renal diets. They consider all these different things. Okay, so what are foods high in potassium? Bananas, right? Cantaloupes, right? Are blueberries high in potassium? I don't think so. I don't think they are. Vitamin C, yeah. But they can have vitamin C. Okay. Okay, so next I'm going to talk about CRRT, continuous renal replacement therapy. And then I'll show you those videos on the dialysis after, because I'm afraid if I stop this, and I don't want to stop my recording, so so I'll show you that after we do CRRT. And that'll be it for the lecture, okay? So what is CRRT? It's for that hemodynamically unstable patient. I would focus on that, right? So it's a 24-hour treatment. It's a method for treating acute kidney injury. Uremic toxins and toxins are removed while acid-base status and electrolyte are adjusted slowly and continuously in a hemodynamically unstable patient. So this is your ICU patient. These nurses are one-to-one. I'll show you a quick picture. Oh, maybe not. Thought I had a picture of it. Nope. That's it, yeah. See that machine right there on the left? That's what it looks like. Imagine managing that. It takes extensive training. These are not easy machines to use. They need to be very, very well trained. Yes, and it's one-on-one. Something goes wrong with these machines, that nurse is, needs to not just pull out a manual, right? They need to know what they're doing, okay? So again, it differs from hemodialysis because it's slow. It's over 24 hours. So it acts just like the kidney, but it's like a slow process for those folks that can't tolerate those massive fluid shifts. Right? So they're not that hemodynamically stable. perhaps they have cardiovascular problems, extensive cardiovascular problems. So this is an option. So they need close monitoring. And they monitor closely their acid-base balances. They'll monitor their electrolytes. Okay. And they can remove large volumes of fluid, but they just do it slower. It's not rapid like hemo. Sometimes it's even used in conjunction with hemodialysis. So just a little bit about the access again. Venous access is achieved with a double lumen catheter placed in the femoral, jugular, or subclavian vein. The blood is pumped and is used to propel the blood through. A blood pump is used. It's a highly permeable membrane with hollow fibers and hemofilter, which will remove the plasma, the fluids, and non-protein solutes, or ultrafiltrate, into the drainage collection device. So it's the same idea, just a little bit different. Okay, and it's 24 hours a day, continuous. These are life-threatening problems such as, people that have really high potassium levels too, uremia, pericarditis. So it kind of uses a blood pump, which is a little different. And it has a hemofilter. The rate is about 0 to 500 mLs per hour, just nice to know. And there's a return port, so the fluid goes through the filter and then returns to the patient. Same kind of way. They do use anticoagulants for this way too, to prevent clotting, and they do that before the filter. So it's ideal that for patients that need control over fluids and solutes, but can't tolerate those rapid fluid shifts like hemodialysis. Okay, thank you. So again, it works by the blood is cleansed and then returned to the patient by the return port, like we said. Fluid and electrolyte replacements can be infused into the port after the filter as the blood returns to the patient. So they can replace their potassium or magnesium or phosphorus right there, right through the machine, which is kind of nice, huh? So they're monitored really closely. So it decreases the unwanted solutes, such as BUN, creatinine, and potassium, and allows for greater clearance of urea, less chance of filters clotting, and they use heparin before the filter. Makes sense, right? Usually if something clogs, it's a filter. Again, same kind of management. What are we going to watch for? Our weight, right? Labs are hourly sometimes, hourly INO. For hemodialysis, they may likely have a CVP, they'll have pulmonary artery pressures. They don't want big changes cardiovascularly, so they'll probably have a hemodynamic catheter in to really monitor closely. Monitor patency of the system. Like I said, these nurses are critical care nurses, and they must know how to troubleshoot these systems. It would be very dangerous if something happens. I've heard of horrible things happening with these systems, unfortunately, but it does happen. And of course, monitor for signs and symptoms of infection at the access site. And very strict what? Aseptic technique, yes. And that is it. Okay. So the last thing I'd like to do one last thing, how do they know when things are getting better with this patient? Like, how would you know? Yeah, labs are going to return back to normal, right? The patient will lose weight. They may be more alert. Their vitals will be stable. Okay, their rhythm will be stable. So lots of different things. Before we're done, I want to show you a video, so don't pack up yet. Okay, just give me 2 seconds. I'm going to just stop my recording.